Good morning, everybody. Sorry, I'll try that again. Good morning, everybody. Dr. Vasquez here, and today I'm going to talk about a few, I guess, divergent, but in my opinion, actually related topics. So, one of the things, I'm going to talk about, I guess, three different things. One of the things that I've thought about for years is how the medical paradigm shifted to my perception around the year 1965. So as many of you know, I've looked at obviously a lot of research. I started just kind of scouring research, I guess when I was about 21 years old, and just spending days and hours in the library, medical libraries. At that point, I lived in Houston, Texas, which is obviously the location of the Texas Medical Center, which is one of the biggest medical centers in the entire world. And we had a pretty good library there. So I used to spend, again, literally many hours, up to days, photocopying articles. Also, when I started at chiropractic college, I used to, again, spend a lot of time just looking at journals. And not simply browsing, but actually systematically going through journals, literally page by page, or at least index or table of contents for every month or every issue, because sometimes they're published on a weekly basis. But just going through all the journals of importance and of interest to me at that time, and just seeing what was available, seeing what was of note. For example, in the Spine Journal, which is mostly a surgical journal related to vertebral problems, I just went through issue after issue after issue, just seeing anything that was interesting. For example, like the fact that people with scoliosis have platelet disorders. That might sound kind of trivial, and probably in isolation it is. But what that shows, or what it suggests, is that scoliosis, and this is just one example, but it just shows that scoliosis is a systemic disease, not simply, a curvature of the spine. And that would then change the approach from a mechanical approach to a systemic or even metabolic approach. So, a single article can have a lot of importance. So again, I went through a lot of journals, week by week, month by month, literally page by page. And I did that for many years. Obviously starting in Houston, Texas, then Portland, Oregon. Portland certainly has some good medical libraries, including OHSU, Oregon Health Sciences University. Then I moved to Seattle. University of Washington, of course, has a great library. So I looked at tons of articles, and through that process, I got the impression that medicine had shifted around 1965. And around 1965, in the articles from those years, I started to notice a change in the approach and the paradigm and the tone of articles. And so that was always just kind of in the back of my mind. So I wanted to talk about that. The reason I'm talking about that right now is because last week or so, somebody sent me a short video clip from Brett Weinstein, where he talks about, he's a PhD biologist who has a blog and a podcast and things like that. But in this particular clip of less than 2 minutes, he talks about how in 1965, the publication and distribution scheme in medical journals changed. And then the way that libraries function changed and the way that journals were edited changed. And so, according to his perspective, at least in that little clip, he describes really a major shift in the way that journals were published, edited, distributed, and obviously, therefore, a change in kind of the landscape of biomedical knowledge in 1965 due to the way they were changed in terms of publication, editing, distribution. And that obviously coincides with my own impression that I had had for years, which was in 1965, something just changed in the paradigms, approach, and kind of tonality of biomedical research. So I'll show you that clip. I'll embed it here in the video.
The whole thing is completely ridiculous. But we have been in the process of dismantling the world's most productive, powerful scientific enterprise from really 1965 or 73 till the present day. And the 65 date dates from Ghislaine Maxwell's father. Robert Maxwell is basically the son of a bitch who introduced peer review, which had only really been strong in the biomedical literature, into general science because he figured out how to make a fortune hacking the universities. If you're a university, if you want to have a complete library, you have to buy all the journals that papers appear in. So he said, great news. I'll jack up the prices and jack up the number of journals. I'll just explode the number of journals. And every university that doesn't want to be incomplete has to buy my product. So suddenly there weren't enough good editors to edit all of these tiny microjournals, Journal of Hyperspecific Thing X. So peer review comes screaming in 1965 through his company, Maxwell's company called Pergamon Press. So Ghislaine Maxwell's father is like the first major attack on science. And then the Mansfield Amendment comes in. There's something called the Eilberg Amendment, 1973. In 1980, there's something called the Bayh-Dole Amendment. Then there's the Immigration Act of 1990. And we're just chipping away at the vitality of American cowboy science. So right now, if you go into a science department, the whole question is, well, what have you done for diversity, inclusion, and equity? Let's agree that there's no lone geniuses in the world, as if we didn't have Einstein and von Neumann and Teller and all these people. Everything is communal. Everything is in the air. It's like nobody wants to work in this environment. Nobody good. Right?
So, again, number one, my impression was that in 1965, around that time, if not exactly at that time, things started to change. And then I got that clip from Brett Weinstein, again, saying that things had changed due to publication and distribution changes, and that affected editing and all the way to the libraries. And I want to tie that into a conversation that I'd actually started a couple of months ago, but I want to revisit right now, and that is the topic of iodine and iodide in clinical practice. So we're now at part number 3 of this casual, spontaneous, after breakfast conversation. And so I want to focus in on some older articles that talk about the use of potassium iodide, especially in the treatment of asthma. Now, I'm certainly aware of and peripherally interested in asthma. I had asthma when I was a kid, but I'm not really that interested in it. What I am interested in is the antimicrobial use of iodine and iodide. And I'm using these articles kind of as a perspective on the clinical use of iodine and iodide. So even though I'm not particularly interested in the treatment of asthma, I am interested in the clinical implementation of iodide therapy. So we're just going to look at 5 or 6 articles right now, and some of these are pretty old. The first one I'm going to look at right now is from 1845. So let's take a look at that, and I'm just setting up my recorder, and here we go. So this is on the use of iodide of potassium in asthma. So, and again, this was published in the Boston Medical and Surgical Journal, 1845. So what I want to establish, or what I think is established by looking at these articles, is that the use of potassium iodide was pretty much standard of care and certainly common practice. And then one of the articles that we're going to look at towards the end here was published in 1980, and at that point they're declaring that no one should ever use iodide for respiratory disease. So again, 1965 into 1980, that's only 15 years. Again, I'm perceiving that things started to shift in 1965, kind of pro-drug and anti-nutrition. Again, possibly anchored back to the way that journals were being edited and distributed at that time. So for example, previously, medical practice was based on risk and benefit And, availability and expenses. Obviously, we have to be practical. But the major considerations were always risk benefit, risk benefit. That was kind of the mantra that doctors had in their mind. So we collectively, medical profession, doctors, clinicians, and certainly the way that I was taught in chiropractic college was always risk benefit, risk benefit. We had none of that conversation in medical school. I graduated from chiropractic college in '96 and medical school in 2010. So 14-year difference between those two. But again, earlier practice was based mostly on knowledge, patient preference, medical ethics, beneficence, non-malfeasance. So first do no harm, provide benefit, respect autonomy, and distributive justice. Those were the four main core pillars of ethics. Doctors don't practice with that in mind anymore. They mostly follow guidelines and they follow what gets published in the big journals. So if we change the way that journals get published and distributed, we're changing the knowledge base, which then impacts the way doctors practice. And in fact, a long time ago, I'm trying to think of the year, I think it was in the 1990s, it could have been in early 2000s, but an article was published in one of the family practice medical journals showing that doctors had shifted the way that they were thinking. They didn't think in terms of benefit to the patient. They thought in terms of what's the diagnosis and what's the drug that goes with that diagnosis. That's a very different paradigm. So this is part of the reason why I like looking at the old research, because it wasn't based on that paradigm. It was based on what's going on with this disease entity and what's going to provide benefit at minimal risk. So again, the old research had a completely different tone and different paradigm, and it resulted in different treatment. And obviously, it was more nutritional and more physiologic and less based on drugs. And again, like I've said before in other videos, I'm not anti-drug. A lot of pharmaceutical drugs I like. And for a lot of drugs, we have no replacement for those drugs in the nutritional or functional medicine world. For some problems, they do need a drug. And I'm not just talking about emergency problems, because that would be even more obvious. But I'm not anti-drug. I enjoy kind of the challenge and the game, so to speak, of skilled prescribing. I mean, that's a whole sport in itself, basically, is knowing when to prescribe the appropriate drug for whatever the condition is within the context of what the patient needs. So I'm not anti-drug. But since the body is developed or designed or kind of evolutionarily crafted, so to speak, to work with nutrients, I think nutrients should be first-line choice, because those pathways already exist for the utilization of nutrients, and those pathways don't exist for drugs. So anyway, going back to this, let's look at this article justifying and endorsing the use of iodide, in this case, potassium iodide. So when we talk about potassium iodide, we're simply talking about two molecules, two atoms, kind of hinged together, so to speak. I presume it would be obviously an ionic bond, not a covalent bond. So we have to, when we think of potassium iodide, the potassium itself is somewhat irrelevant. It's just a kind of an anchor or a buddy that goes along with the iodide to keep it in its monoatomic form, if that's the correct phrase. But usually, yeah, I guess it would be. Usually iodine as a natural element is diatomic. So it would be two iodines connected together. Most of the time that iodine is used, it's used in the iodide form, which is iodide, an iodine molecule connected with something else, whether it's sodium or potassium. So in this case, of some relevance is the fact that when we look at higher doses of potassium iodide, we have to be aware that that's also going to carry a cargo of potassium. That's irrelevant most of the time until we start getting into high doses of potassium iodide, in which case the potassium content, I believe, is 28% by weight. So, for example, if we were to use as much as 10 grams of potassium iodide, 2.8 of those grams would be potassium, and then the remainder would be, the 7.2 would be iodide. So then you have to know what's the physiologic kind of requirement or tolerance or need for potassium in the human body to know if the 2.8 grams of potassium, is that too much? Is it toxic? Is it dangerous? Whatever. Maybe it's not enough. Or maybe some of the therapeutic benefit of potassium iodide is coming from the potassium. And that is, I do think that that's true. So as the dose of potassium iodide gets higher, the content of potassium, the load of potassium, obviously the percentage stays the same, but the load is going to be higher of potassium. So as patients with more severe disease were treated with higher levels or higher doses of potassium iodide, they were also therefore obviously receiving more potassium, which was providing its own pharmacologic benefit. Specifically, and of course they didn't know this back then, but specifically, potassium has an anti-inflammatory effect. It inhibits a pathway called the NLRP3 inflammasome, which is kind of the maturation factory, so to speak, of pro-inflammatory cytokines like interleukin-1. So when we think about mechanisms and benefits, part of the benefit of potassium iodide therapy could have been, and in my opinion, most likely was, at least partly attributable to the potassium itself. So let's go back again, 1845. What were they saying about potassium, 170 years ago? So I'll make a few notes or arrows along the side, and I will color those. I guess today's color is going to be purple. So he says, within the context of addressing potassium, in the context of addressing asthma, he says about these patients, to our mutual delight, they were all more or less speedily relieved. I have now made use of the medicine in some 25 or 30 cases of asthma, some of them very severe and aggravated. And so far, in no one instance where a fair trial has been made has it failed to afford unequivocal and decided relief. So from the perspective of clinical benefit, this is obviously a very strong endorsement. He talks about duration of treatment and a few details. Eventually I'll post these articles on the website. I think what I'm going to do is summarize each one of them, and I think then I'll provide the PDF of the original articles, which is what you're looking at here. Obviously, this isn't the paper article, it's a scanned copy. This author does talk about some of the adverse effects of iodide. He says here, a long continued use of iodide of potassium will, in some subjects, occasion an eruption. It's considered kind of like what's called an acneiform eruption, which just basically looks like pustules and acne on the face. Generally of a pustular form, slight conjunctivitis, so sometimes people get a little bit of eye irritation or they get a runny nose, and he discusses some ways to address that, in this case with rhubarb and soda, he says. Most of the other clinicians that I'm going to review their articles, they talk about just reducing the dose a little bit. So I think that's the end of this one. So again, this author in 1845 describes tremendous value using potassium iodide, a little bit of adverse effects that are mostly negligible and transient according to his perspective, and he certainly endorsed it. Now let's look at another article. So we're going to go from 1845 now to 1955. This is a very short article published in the Journal of the American Medical Association. And let's take a quick look at this one. Oh, very interesting. So he talks about the intravenous use of sodium iodide. So remember, I said potassium iodide is iodide with potassium. It could just as easily be sodium, especially for intravenous use. So he talks about using intravenous sodium iodide for status asthmaticus. I have seen status asthmaticus cases dramatically relieved with the expulsion of large amounts of thick mucus by its use. So again, another endorsement. And this is just a small, obviously a very small article, but I'm just including it for perspective. So again, another good endorsement here. Let's go on to the remaining about 4 articles. Let's take a look at which one this one is. So I think we'll look at this one. The other ones are from 1969. So this is 1964. And then we'll go to 1969, and then we'll go to 1980, and that's it for today. So this author talks about the asthma suppressive action of potassium iodide. Mostly what I want to focus on here is his description of the dosing. So they used 300 milligrams. Each tablet was 300 milligrams. So 2 tablets would be 600 milligrams, and they did that 4 times per day for a total daily dose of 2,400 milligrams. So that's 2 grams, or 2.4 grams per day. And that was the standard dose. Here he's applying that in a 34-year-old man. The second case he describes 10 cases here, I believe. The second case is a 37-year-old woman. She got the same dose. Case number 3, a boy of 12. Let's see what he says here. A boy of 12 had rhinitis since infancy, usually worse in the summer, then developed asthma. A couple different interventions were used. While in status asthmaticus, only partially controlled by cortisone, he was first started on 2 300 milligram enteric-coated potassium iodide tablets. So it's 2 tablets of 300 milligrams 4 times per day. So that's the same dose used in the adults, with clear-cut relief apparent in 5 days. So one of the things that this author talks about is that when patients were dependent on steroids for the control of their airway inflammation manifesting as asthma, that a lot of times just using iodide, they could reduce the dose of steroids or eliminate the need for steroids. And that's hugely important because those anti-inflammatory drugs, steroids, and they're wonderful drugs. I love those drugs. But long-term use obviously has negative effects like osteoporosis, diabetes, hypertension, steroid psychosis, and immunosuppression. So again, if we could eliminate or minimize the use of steroids by using a natural element like iodide, that would be great. Here he describes another patient using the same dose, 2.4 grams per day. And the reason that I'm emphasizing the dose is that for us, including me, for us collectively to use this therapy, we have to be comfortable with the dosing. So that's why I'm repeating what the dose was, 2.4 grams per day. And again, he says here, for 2 years, this patient has remained completely well on iodide without supplementary medication. So when the paradigm started to shift in medicine against nutrition and more in favor of drugs based on the power, let's say, or the apparent power or the illusory power of drug studies and statistical manipulation. See, a lot of the earlier studies, and this is an example, studies that were practitioner-based were not based on statistical significance. They were based on clinical relevance. Huge difference. So again, somewhere between 1965 and 1980, that paradigm shifted away from what works toward what appears to work. Huge difference. So we went from clinical effectiveness, otherwise known as absolute effectiveness or absolute risk when we talk about preventive studies. So here we're looking at an absolute benefit versus a relative benefit in the drug studies. So what I saw in the research, and again, this is an example, this is 1964, perfect, is the shift was away from small studies that showed actual benefit into huge studies funded by drug companies that showed theoretical benefit. That's a huge distinction. And again, somewhere between 1965 and 1980, that's when all of this shifted. Some of my favorite medical books, well, were the older books, but written in the 1970s, early 1980s, for example. One of the books that totally changed my life was Mega Nutrients for Your Nerves. I think it was written in the 1980s, maybe 1984. It was written by a medical doctor named H.L. Newbold. It's one of the few books that I've carried with me internationally throughout my various relocations. But it is for me an important book. Here's another patient, age 14, again using the same dose, 300 milligrams, 2 tablets each. So that's 600 milligrams, 4 times per day. That gets us to 2,400 milligrams, 2.4 grams per day. So again, that was the standard dose, at least in this author's perspective. This was a report of 10 patients, I think he said out of 200. So this shows a pretty miraculous benefit. And these are difficult to treat patients. These are not just walking down the street asthma. These are patients, a lot of times, who came to specialty clinics, as we'll see in one of the next reports. So this is not, oh, I'm a little short of breath. This is short of breath and dependent on multiple drugs, up to the point of status asthmaticus in hospitals. And they still got a 5% benefit, more or less, at least that's what it reports here. So 5% is 1 out of 20 patients had a really significant benefit here, but those were the more severe patients. And believe me, 1 out of 20 doesn't sound like a lot until you compare it. Go ahead. I challenge you, I dare you, compare that with some of the most popular drugs on the market. The antidepressant SSRIs. They don't come anywhere near 1 in 20 benefit in the real world. Now, I'm not talking about relative risk in the drug-funded studies. I'm talking about real benefit in the real world. SSRIs don't get close to that. And they sell millions, billions of dollars a year in SSRIs. So this measly, so to speak, 1 per 20 benefit is actually quite big when we compare it to some of the most popular drugs on the market. SSRIs, statin drugs to control, supposedly lower the non-problem of elevated cholesterol. And look at the COVID vaccines. The COVID vaccines showed a relative risk reduction of like 90%, but the absolute reduction in the real world was about 1%. Huge difference, don't you think? So the earlier data, like this report, it might show that the percentage was relatively small, but at least it's real world data. We don't get much real world data anymore because the big studies funded by drug companies and then accepted blindly by government pawns who don't know how to read research, they look at relative risk, which doesn't tell you virtually anything about absolute risk reduction or absolute effectiveness. So another way of saying this is I would take a 5% real world benefit any day over, a supposed bigger number that's just a relative risk reduction, which doesn't have any clinical meaning. Again, the dose being used is 300 milligrams, 2 tablets, 4 times per day for 2,400 milligrams. And toward the end of the article here, he talks about some of the adverse effects. So let's look at that, and then we'll move on to the next article so I can keep this as short as possible. 2,400 milligrams was the standard dose for adults and children, sometimes going up to 3,600 milligrams. Let's see if he talks about dosing. He does say per day right here. Let's see if he talks about changing the dose. I don't think he does in this article. He does say it should be avoided in tuberculosis and in pregnant patients as well. He talks about it being used in syphilis and a fungal infection called sporotrichosis. Let's see, he does talk about adverse effects. A little bit right here. He talks about kind of skin eruption again, controlled by reduction in dosage, edema of the lids and face, and including the parotid glands. Yeah, he does say parotid glands right here. I should have highlighted that. I'll highlight it right now. And so they just modify the dose. What he doesn't seem, and maybe he does, and maybe I'm just skipping over it, but what I don't see emphasized in this article, which is emphasized in the next two articles that we'll look at, is not dosing it every day, but dosing it 4 days on, 3 days off. That seems to help control some of the adverse effects, but without reducing the effectiveness. So let's see what he says here in the conclusion. So summary, the exceptional asthma suppressive action of potassium iodide was discussed in these 10 cases out of 200. So again, 10 out of 200 would be 5 out of 100, which means 5%, or 1 out of 20. I'll still take it. Now, certainly I, in clinical practice, would never use this as monotherapy. Obviously, these days, again, let's assume we're talking about asthma, we have a lot of different treatments. Magnesium, vitamin D, vitamin A, NAC, modifying the gut microbiome, reducing systemic inflammation with different botanicals. We have a lot of natural leukotriene inhibitors, which parallel the anti-leukotriene drugs. So we have a lot of options. I'm not advocating, this as monotherapy, but it does show some benefits, so I think it would be reasonable to use. Let's move on now to the next two articles. This is a short article by Christine Bernecker from Germany. Let's take a look at what she says here. 1969, British Medical Journal. She's more clear, and I think she actually has more experience. She's more clear on dosing the iodide 4 days on, 3 days off. So let's talk about what she says here. She's treated 2,400 patients. We're going to look at her big review on the next article, and she talks about 3.6 grams up to 36 grams per day of potassium iodide. Now, I wouldn't be comfortable going that high. Most people wouldn't, but at least it shows, what's possible. Anytime, like one of the ways that I've studied nutrients is to know what is the upper limit of safety or survivability. And in this case, she says 36 grams. The dosage of potassium iodide varied from 3.6 to 36 grams daily. And she talks about using it given for 4 consecutive days, followed by a free interval of 3 days. So 4 days on, 3 days off, just like we do with chelation therapy using DMSA. She talks about adverse effects in 7% of patients. Iodine coryza, so it's just runny nose. Swelling of the salivary, the parotid glands, which is usually transient, according to, I believe, her second article that we'll look at here. And stomach upset. So those can all be managed by discontinuation or reduction in dose. The other long-term consequence is hypothyroidism, which again, they address with dosage reduction, discontinuation, or the administration of thyroid hormone. Now, patients with allergy, asthma, atopic, and inflammatory conditions are more likely to have thyroid problems. So a possible interpretation of the relationship between iodide therapy and hypothyroidism is also to say that some of those patients were probably going to develop hypothyroidism, or they were already developing it, and with the course of time, or exacerbated by this therapy, they then manifested hypothyroidism. The other thing that I want to say is, even though iodide appears to have a bit of an antioxidant effect within the thyroid gland itself, I think it's probably pro-oxidant. And so one of the things that I think we would certainly do now that they didn't do back then is we would use antioxidant therapy when we're using higher doses of iodide. And the two most important antioxidants in that regard are selenium and vitamin E. So that would be a way to address some of the thyroid concerns as well. Let's take a look at her bigger article here, also published in 1969. I'll start at the top of the article. So this was published in Acta Aerugologica in 1969. That journal has been retitled as Allergy, the official journal of the European Academy of Allergy and Clinical Immunology. But here we were at 1969. She's going to review her experience from a specialty clinic in Germany, 10 years of experience. And let's see what she says here. Talking about specifically in airway obstruction, so mostly asthma, but also what she calls congestive bronchitis secondary to congestive heart failure, which is obviously a completely different pathophysiology. So she talks about using potassium iodide in 2,404 patients over the course of 2 years. So this is obviously quite huge, especially for those dates. Again, these are not just routine run-of-the-mill walking down the street asthma patients. These are patients with difficult to treat asthma that requires specialty care. So she describes about 1,000 men, about 1,000 women, and 100 children. These were difficult to treat patients who required corticosteroids. They had all been hospitalized, most of them, or a lot of them, let's say. So these are, again, severe cases. And some of them, chronic bronchitis was caused by heart failure and chronic congestion of the pulmonary circulation. The routine procedure was as follows. And then she describes that being 3.6 grams per day. So again, this is from a specialty clinic in Germany. If you remember, and I'm sure you do, the American approach seemed to have been more at 2.4, not 3.6 grams per day. So up to 4.8, she says here. And again, 4 days on, 3 days off. So even though this is a higher daily dose, probably the cumulative dose would actually be equal to or less than what I was just referring to as kind of the American dose, because she's only using it for about 60% of the time. So that would change the pharmacokinetics of what's going on here, because what she's doing here, instead of daily dosing kind of at a lower level, she's not quite, but moving in the direction of using what we would kind of think of as pulse therapy. So she's using a higher dose and then peak and trough, peak and trough. Theoretically, and I'm not saying that it occurs with that dynamic, but with that type of dynamic of peak and trough, you would expect different physiologic effects. For example, you would expect greater tissue concentrations based on the higher level in the plasma, in the blood, and that could affect greater tissue penetration, especially combating microbial colonization and biofilms, for example. So when they talk about the use of iodide, they're mostly talking about removing mucus, mucus plugs, phlegm, its expectorant properties. They're not thinking in terms of antimicrobial effects, even though, of course, everybody has always known that iodine and iodide are antimicrobial. They were thinking in terms of maybe an anti-inflammatory effect, but certainly kind of clearing out mucus. They weren't thinking in terms of modifying the gut microbiome or the lung microbiome or the nose and throat microbiome. They weren't thinking in those terms, even though my interest in this therapy is that is how it works. I think that iodine and iodide systemic therapy functions not solely, but importantly, through modification of different microbial populations in the gut, in the lungs, and in some of the internal organs. And I'm especially interested in, brain dysbiosis, so to speak, but also pancreatic dysbiosis. A lot of people appear to carry fungal infections within their pancreas, but also within their brains. So I'm interested in iodine therapy from the perspective of a systemic poly-antimicrobial benefit to address things like multiple sclerosis, Alzheimer's, pancreatic cancer. So that's the perspective that I carry looking at this research. And that's why I'm interested in what's the safety and what's the risk. So I'm using this to kind of inform my therapeutic approach with those other considerations in mind. Again, Alzheimer's, fungal infection of the brain, multiple sclerosis, bacterial infection of the brain, pancreatic cancer, fungal infection of the pancreatic gland itself. 3.6 grams up to 4.8. This improvement occurred within 12 to 24 hours, she says. So obviously, her baseline appears to be 3.6 grams per day. More severe cases would get more. Less severe cases would get, of course, the lower dose. And here I talk about what I've mentioned before. Again, it's potassium iodide. The potassium component is 28% by weight. So at the higher levels of dosing of potassium iodide, we have to think about the potassium load itself. I think for most patients, that's probably a good thing. The official recommendation for potassium intake is 4.7 grams per day. So if a patient were to use a huge dose of potassium iodide, they would be at 5.6 grams of potassium per day. Again, that's pretty much in the ballpark of the common recommendation, which is 4.7. Again, I mentioned here, potassium provides anti-inflammatory benefits by interfering with the NLRP3 inflammasome. So that could be where some of these benefits come from. But otherwise, what would be the mechanism of iodide? Anti-inflammatory, antioxidant, antimicrobial, which I think is huge, but also modifying estrogen receptors for another immunomodulatory effect. Immediate side effects, parotid glands swelling, she says. Runny nose, headache, and gastrointestinal upset are the ones that are most commonly mentioned. She mentions gastrointestinal upset right there. Long-term treatment, hypothyroidism. Again, probably a lot of these patients were already on their way to thyroid problems. But it's still important. I'm not discounting it. I'm just trying to understand it. Reduction in doses for adverse effects. So I do want to point out something here, and I'm going to talk about this in another video. Iodide appears in the bronchial secretion of man in direct proportion to the iodide plasma concentration, which is obviously dependent on the oral dose. So a bigger oral dose puts more in the blood, and that puts more in the secretions and more in the tissues. A different article that I read, and I cite this in my book, Inflammation Mastery, a different article, which I'm looking for. I'll probably just go back and look at my own book. I wonder if I could do that right now, actually. I don't know if I could. I do have the book nearby. Okay, we'll try it. So I'll give this 60 seconds. And we'll see if I have it in there. Because I do have the book right here. I think it was in the diet section, so that would have been chapter 4, section 1. So here's my own book. Let's just see if I find it real quick. Let's see. Yeah, well, here we are. Let's see if I don't know if I included that article, but I am looking. So it's on page 324, where I talk about the use of iodide in sporotrichosis, another fungal infection, fibrocystic disease of the breast, cystic mastalgia. So that's when women get kind of breast pain with their menstrual cycle. Yeah, I don't think that I included that in here, but what I am thinking about, again, here's my book, Inflammation Mastery. Quite the book. What I am thinking about is an article that I apparently read but didn't include in the book, which was showing that from the moment of oral supplementation with iodide, it appears within the bronchial secretions within 15 minutes. So that's very rapid effect. supposedly for the mucolytic benefit, but also, again, reducing the total microbial load within the mucosal surfaces. So again, it was 15 minutes. I'll have to go look at find that other article. It was a paper article that I actually photocopied at the Texas Medical Center Library back in, that was 2004 to be exact. Let's see. Swelling of the parotid glands again. Basically, she describes it as not a big deal, even though, of course, it's alarming. Stomach upset. So here's her summary. In a high percentage of patients, the treatment loosened mucus, improved their breathing ability. Again, asthma or kind of congestive bronchitis. Acne, runny nose, swelling of the parotid glands, stomach upset, hypothyroidism. So anyway, that's her approach. Let's see if she repeats what the typical dosage was, if she repeats that in this area. Apparently not. But again, this was standard therapy up until almost 1970, so this was published in 1969. Now let's see what happens in 1980. In 1980, we see this publication, which was actually published twice. That's not considered to be ethical, but apparently that's what they did here. Saying it's time to abandon the use of iodides in the management of pulmonary disease. So like I said before, around 1965, things started to change. We started to see everything being kind of shifted towards drugs and away from nutrition, toward relative effectiveness versus absolute real-world effectiveness. And this article supports that observation, which was somewhat casual, but I think is getting stronger. So here, they're taking a treatment that was previously recognized as standard of care, and now they're saying, oh, you have to abandon it, don't even do it. And their rationale is based on the fact that it didn't help a lot of patients, even though, again, I would prefer a real-world percentage of real benefit versus a study published by drug companies showing a relative or theoretical benefit. That's a miracle. I mean, it looks great on paper versus something that looks great or at least modest or beneficial in the real world. They do, of course, talk about, if not overly exaggerate, the adverse effects. So anyway, I'm just pointing out that shift. So again, I've kind of carried this idea with me for many years that around 1965, things seem to have changed. So I wanted to make that point at some point, and I'm making it right now. When I saw that video clip from Brett Weinstein saying that, yes, in 1965, things started to shift, we see that, 15-year period between 1965 up to 1980, now they're condemning what was previously the treatment of choice, or a treatment of choice, or certainly standard therapy, saying, totally abandon it, give it up. Don't even include it as a side therapy or a partial therapy, but abandon it altogether. And that just doesn't make any sense. And I think that this reflects the pharmaceutical kind of takeover and hegemony of journals as the publication model shifted. That changed the way that journals were edited. That changed what got published. Drug companies started, using advertisements in medical journals. That obviously influences the editors because the editors have to maintain the financial survivability and profitability of the journal. So they want advertisers. Well, those drug company advertisers want a curated market or a groomed market. So they're going to preferentially put their ads in journals that publish positive studies for their drugs because now the audience is more receptive to the advertisement. So the advertisement is paired. You have a drug advertisement here along with a positive study here. They obviously go hand in hand to promote drug sales. So you see, how this whole thing began to shift when publication and distribution changed. That changed editing. That changed, preference for articles based on profitability for the journal, which was, of course, based on drug advertisement as well as circulation. So all of that changed, around 1965, or started to change. Obviously, any change is going to take a few years to cascade or domino its effects. But again, somewhere starting at 1965, 1980s, we saw a huge shift in the tone of articles, the emphasis of articles, again, going from real world experience and benefit to this theoretical la-la land of relative risk reduction. And through relative risk reduction, they can sell worthless drugs like SSRIs, statin drugs, including these injections. They can sell worthless drugs based on a statistical finding of relative risk reduction that in the real world of absolute risk reduction means absolutely or close to nothing. So those are the points I wanted to make. Thank you very much for your attention. We're at 49 minutes, and I'll get this edited and posted on the website as soon as possible. And thank you very much again. This has been Dr. Alex Vasquez at inflammationmastery.com and healthythinking.substack.com. Thanks, and I'll get this on the website. And eventually I'll put the articles on the website as well, after I've had a chance to actually summarize them and then put them in the new edition of the book. But speaking of the book, this book is really not going to change very much. So I published this in 2016. Obviously, at least the fourth edition. I mean, I've curated this data for a long time. I don't expect any, even if I were to republish this in 2 years or 3 years or 5 years, the core material is not going to change. A few more details here and there, maybe, but I'll put those on the website anyway. But the core is not going to change. In fact, I'm going to kind of challenge myself, and that's what I'm working on right now. A lot of new articles have come out on mitochondrial function, just as an example. And of course, I have an entire section in here on mitochondrial function. So that would be chapter 4, section 3, I believe. No, chapter 4, section 4. So I am going to look at that new data on mitochondria, because what I want to see is if the new data on mitochondria changes my information on mitochondria. So the question that I'm going to try to address, let's see if we look at a picture of a mitochondria. Yep. The question that I want to address in some upcoming videos is, does more information about mitochondrial details, so to speak, does that actually change the paradigm? So obviously some things are never going to change, but what I want to see is, does the next generation of information over the past 10 years, does that actually change what I've put in here as my protocol? So I'm going to review that in some upcoming videos, and I'll tell you, we'll look at the articles, and maybe more details will refine my own protocol. I suspect that it won't, but I'm certainly willing to look at that and see if, more details, wow, I need to change my protocol, or more details, wow, now we know more, but it doesn't really change what we do. So that's the next project that I have in mind. Now that I've taken care of reviewing Anthony Fauci in the New York Times, with the ultimate conclusion that it was pure propaganda and garbage, and he showed what a completely pathetic leader he is. I can't even say he's a bad leader, because that would describe him as a leader. So he completely mismanaged his position. So I'm very clear on that. Now I wanted to talk about this topic. Next topic is going to be mitochondria, kind of the next generation of data, to see if that actually changes therapy or not. I suspect that it won't, but let's see if it does. So that's what's coming up soon. So take care, and I'll see you soon on video.